I'm going to call the meeting to order. Good evening. Welcome to the February 13th, 2013 meeting of the Washington Township Healthcare District Board of Directors. If you'll join with me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Catherine, can you call the roll?
Yes. Director Nicholson?
Present.
Director Stewart?
Present.
Director Wallace?
Present.
Director Danielson?
Present.
Director Dufresne?
Present.
Great, thank you very much. We'll move on to our educational session. And Nancy, can you introduce our speaker?
I'm going to begin by asking Ed to come forward and introduce the subject. Tonight, we're going to hear a report from the Measure FF Citizens Bond Oversight Committee. It's their annual report. And Jack Balch, the chairman of the Measure FF Citizens Bond Oversight Committee, will be presenting to the board. I'd like to remind people that the necessity for a Citizens Bond Oversight Committee was not stipulated in statute. It was something the board elected to do for the benefit of our residents. With that, I'd like Ed to do his introductions.
Thank you, Nancy. So we're here for the fourth visit to the board to give the annual report from the Bond Oversight Committee, which had oversight responsibility for the central plant and related central plant projects, for which we utilized bond funds from Measure FF. So this is a committee that was set up as a result of Measure FF. And so annually we come forward and report on what the financials have been for the projects, and also the utilization of the bonds that came from Measure FF. So you might remember that in 2004, Measure FF was passed specifically for healthcare buildings at the Washington Hospital Healthcare District, and it had specific purpose behind these bonds, and they were to make the required state upgrades for earthquake, expand our acute care facilities, and also improve our building systems and capacity to increase operational performance and reliability of our different utility systems. And that was the main focus of the central plant project. As you might remember, Measure FF delineated that the healthcare district would get $190 million in general obligation bonds that would be utilized to reimburse the expenditures for construction. Our Bond Oversight Committee is made up of Kevin Hom, Al Hueso, Jack Balch, Garrett Yee, and John Lowe. And Mr. Balch is the chairman of the committee. And let me just give you a quick introduction of Mr. Balch. Jack is the president of Balch Enterprises, Inc., a family-owned company in Hayward, California. Balch Enterprises has evolved into a full-service, vertically integrated builder-developer specializing in the development and construction of concrete tilt-up buildings. The company has been listed as one of the largest developers and property managers in the Bay Area. Jack is an original member of the Bond Oversight Committee and is currently the chairperson. So with that, I'd like Jack to give the report.
Well, thank you very much for allowing me to be here. As you're aware, the project came in on time, actually a little bit ahead of time, and on budget, actually under budget. While there may be some slight adjustments to the overall numbers you're looking at, they should be substantially as presented. And I think a lot of this has to go to the decisions made by all the people involved. The board here making the decision to do a design-build contract, I think that was the smartest decision that you ever could have made. I think that saved you tens of millions of dollars. And I think your staff did an absolute excellent job of watching cost. We were kept aware of cost as we went. We were kept aware of the amount of work that was proceeding. So we always had a very good idea that money was being spent to the work that was being performed, and I think the results show what a good job they did. I believe you've all been through the building, and I will show you pictures of it. It came out very nice. You can be very proud of yourself. Got to get my notes here. Right now, with the financing, you've sold approximately $85 million of bonds, and you've made another about $5 million of interest. You've spent about $70 million of the money, and you still have $20 million remaining without selling any additional bonds to start the next phase. Right now, we're kind of in a wait mode while we get to the next chapter of building out here, but I think you've left this hospital in an excellent position to continue and do a good job. Thank you.
Thank you. Thank you, Jeff. Any questions from the board?
I just wanted to say that you folks on our Oversight Committee have done a wonderful job, and as Ed noted, your company is headquartered in Hayward, but you've been a Fremont. You're currently a Fremont resident. You've been a Fremont resident for as long as I've known you, anyway. So
Over 50 years, I think now.
50. You're that old? Or that young? What do you mean?
Yeah, that young.
Well, thank you, Jack.
Thank
Good.
you.
Yeah, Jack, on behalf of the board, and more importantly, on behalf of the community, we'd like to thank you and the other Oversight Committee members for your really hard work that you do in ensuring that what the voters intended with those bond funds are used exactly for what they are intended for. So we really appreciate that, and I think you're going to get a sense of how sincere that appreciation is later on in our agenda when we look at reappointment to Oversight Committee. But thank you again, and please convey our thanks to all of the all of the Oversight Committee members.
Thank you very much.
Great. We'll now move to consideration of the minutes of the December 6, 2012 meeting, as well as the January 9th, 21st, 23rd, and 28th meetings of this year. Do I have a motion?
Move for approval.
We have a motion.
Second.
We have a second from Dr. Stewart. All in favor?
Aye.
Aye.
Any opposed? Motion passes. At this point, we will entertain oral communications from the public. Catherine, do we have? Mr. Bob Spider Cantley.
Good evening, ladies and gentlemen. I had occasion 4 or 5 months ago to communicate with CEO Farber with copies to the board pertaining to my concerns about what I felt was a community issue. I've already heard community mentioned this evening, so from that standpoint, I'm sure we're on the same track. In a nutshell, when I received the response from CEO Farber, it detailed the situation pertaining to the Joint Replacement and Research Wing, very professionally, very detailed, and so on. There was no mention of the fact that I had asked for an opportunity to speak to the board. My position is this. When I had my bilateral knee surgery 4 or 5 months ago with Dr. John Giorgito, I fully intended to, or expected to, have my rehab or therapy instructions, etc., take place in the new wing. I didn't know otherwise. When I went into the regular hospital, I did get my instructions in there from 2 very competent therapy gentlemen. Let me preface this by this. I'm not anti-Washington Hospital. My family has been involved with Washington Hospital services, care, and what have you for 45 years. This issue, as far as I'm concerned, is a community issue. So when I wasn't allowed to be in the new wing, so to speak, I was in the main hospital and in a miserable set of circumstances on the 6th floor, down the end of the hall, maintenance wing or maintenance department back there. And for myself and the other 4 or 5 patients, frankly, it was miserable. as compared to the Dearborn room in the new wing, where I had a chance to speak to 15 or 20 people that had had new joints. And I just said, hey, you follow what your therapist tell you? Great, you're going to come out fine. Mine has worked out fine, and that's the way to go. But as I pursued it further, and I read the criteria that was supplied to me by CEO Farber, I mean, just reading through it, I mean, just absolutely exclusionary and prejudicial, my opinion initially. I made copies available of the criteria to doctors and researchers that I've dealt with around the country, at the Fred Hutchinson Institute, at the Mayo Clinic, at MD Anderson in Texas, because I've been involved for many years raising funds for cancer research for Leukemia and Lymphoma Society. So the general impression that I received verbally was that, yeah, it is very tight, very narrow as far as who could meet these needs other than Dr. Dearborn and Dr. Serg. I did speak to Chris Lavoie, and she said that the legal people pertaining to the hospital said that the way it was written, that it was completely legal. My question was, it may be completely legal, but was it completely right for the community from the standpoint of health care, quality health care, which is also mentioned in this letter? There's a comment here that we wanted the patients within Washington Hospital to get equal care. I did not get equal care. There was no comparison where I was treated as opposed to how I might have been treated in the ultra prime, new wing, clean, germs, etc. And I'm not an elitist. It's just my opinion that the manner in which it was handled was wrong. To only have two surgeons operating out of their patients operating out of that wing, to me, was totally exclusionary. And then I received in the mail a questionnaire, a satisfactory questionnaire pertaining to my experience in the new wing. And it appeared to me that the left hand and the right hand weren't on the same page, because I wasn't allowed to get my therapy and my treatment, etc., in the new wing. So again, it was a contradiction. The community as a whole, and I have 5 or 6 or 7 doctors as a longtime resident of Fremont, and that had occasion to speak to one-on-one pertaining to the manner in which the Joint Replacement Research Wing is being used. There's a level of discontent in this community, not just with other surgeons who were excluded and their patients the use of the wing, but just a general discontent about the manner in which the criteria is written, the way it's presently used, the exclusionary nature of how it's presently used. And I wasn't prompting them. I was asking them their opinions based on my own experiences. So as things progressed, I became more and more aware of the fact that, I should pursue it. So I wrote the initial letter to CEO Farber with the hope that at some point in time, maybe that very narrow criteria might be altered so that other surgeons that work, like my Dr. Jerry Guido, I guess he's been here 10 or 15 years. He's worked on myself prior, my wife prior. Moses Tagihoff probably saved my wife's life, which I mentioned in the letter. So it was a glaring problem to me that this 3-story multi-million-dollar wing, and I questioned whether or not public funds were used to build it in a community hospital. When I spoke to Chris Lavoie, and also in this letter, it doesn't indicate that no public funds were used, that there was a benefactor, or that Dr. Dearborn paid for it himself. So none of those conditions seemed to be the case. And that further moved me in the direction of pursuing what's right and what's wrong. My final comment in my letter was, I understand the bottom line. Been in construction business for 50 years. I know you gotta have a profit. And if you don't have a profit in the whole hospital as well as in the new wing, it's a serious problem. But my comment was, at what point does revenue trump quality care and the oaths that the doctors around here have all taken? I think the manner in which the new wing is presently being used is really exclusionary and prejudicial to the other surgeons that might well have their patients in that wing. I don't know if it's going to be looked at further in the future. I certainly hope it will. I'd like not to take it any further, and I will, if need be. But the cross-section of you around this table and your particular backgrounds, and I looked at the description of who's who and what have you. And as I mentioned, I've got a lot of years of experience in Fremont, a lot of years of experience with this hospital. I would hope that the board would take a serious look as to the manner in which the Joint Replacement and Research Wing is presently being used, and possibly open the door to a broader use by other surgeons and their patients. It's not so much the surgeons. The operating room, my experience was excellent as far as the end result. I draw the line where it wasn't excellent at all as compared to how it might have been had I been able to do my rehab, etc., in only the 3 days that I was here in the new wing. And in a nutshell, that's my concern. And I would love to see the board consider it further in the future, because right now, within the medical community, you have a lot of unrest. And I don't think that's a positive for the hospital or for the community in general. And again, when I come back to the point that it's a community hospital serving the public in no way, shape, or form should be excluded from the new wing. And I thank you very much for giving the time to let me explain my feelings. Thank you.
Thank you for your comments, Mr. Cantley. We'll move on to written communications. Dr. Romano, or credentialing action items.
Okay. These are the credentialing action items for the month of January. We have 2 new appointments. Elizabeth M. Arias in internal medicine to the provisional active staff, and Philip Lee, also internal medicine, and also to the provisional active staff. We are recommending reappointment for the following physicians: Stephen Belton, OBGYN, to the active staff category; Bhupinder Bhandari, gastroenterology, active staff; Gordon Epstein, otolaryngology, active staff; Puya Jazieri, anesthesiology, active staff. Excuse me. Clara Kang, pediatrics, active staff; Chai Kong Lau, internal medicine, active; Yung Ting Lau, pediatrics, ambulatory; Don Lu, intensivist, active category; Bruce Nixon, radiology, active; Omandi Nyango, ophthalmology, active; Harry Puri, pediatrics, ambulatory; and Lucia Yumena, nephrology, active. We're recommending transfer in staff category for Dr. David Burke, cardiology, from ambulatory to active, and Clara Kang, pediatrician, from active to ambulatory. We are recommending that you discontinue proctorship for Clarabelle Taylor in gastroenterology and Jonathan Bradley in anesthesiology. They will remain provisional active members. We would like to recommend extending the proctorship and provisional category for Mary Maish, thoracic surgery. And we would like to extend the proctorship and the provisional category from March 1st through August 31st for Anjali Kanpal in family medicine. That physician will remain on the provisional active staff. And finally, we have 1 resignation, Nancy Pham Thomas.
Great. Thank you very much, Dr. Romano. I'd like to notify the rest of the board that I will need to abstain from action on this item, as my wife, my Valentine, Dr. Lucia Yumena, her privileges are being acted upon tonight. So if I could have a motion?
So moved.
Second.
We have a second from Ms. Danielson. All in favor?
Aye.
Okay, motion passes, and Catherine, please note that I abstain. Sharon,
Good evening.
This is your last time, isn't it?
This will be my last report as the Service League Board President. It's been a really transitional year for the Service League business, as far as it's concerned. We've accomplished a lot, and the board has all pulled together to bring the league new and exciting changes while still holding on to our valued traditions. The Service League made many changes to our newsletter and to our standing rules. We examined our bylaws, awarded 4 scholarships, and purchased a new gift shop point-of-service system. We brought on additional coordinators for large service areas, held 2 jewelry sales for the employees and community, and contributed $10,000 toward Measure Z. Additionally, our annual contribution to the hospital this year is $55,000 toward upgrading the security system. I hope you've enjoyed the changes. Being on the Service League board is interesting and fun work. However, it's time for a change in our board. At our annual meeting, we elected the following board members: Jeannie Yee, President; Gail Tamita, First Vice President; Deborah Jackson, Second Vice President; Diane Zarzinski, Secretary; Shirley Crockett will continue as Treasurer, and I will be the parliamentarian, Sharon Stagg. I'd like to say a special thanks to Dr. William Nicholson, Nancy Farber, and Dr. John Romano, who took time out of their busy schedules to speak at our event. Thank you. The words of thanks and encouragement are very valued by the members of the League. I've thoroughly enjoyed this year. It's been an honor and a privilege to serve as the Service League President. Thank you.
Thank you so much, Sharon. It was my privilege to be able to speak at your annual meeting.
Very well received. Thank you.
It's such amazing work that you do, and you've made such great progress.
Thank you.
So we look forward to your work as parliamentarian and to Jeannie taking over as
Yes.
president.
Should be
So,
great.
I'd like to present to you a token of our appreciation,
Oh, how sweet. That's a nice surprise.
especially appropriate for Valentine's Day. You are the board's Valentine.
Thank
Because
you
you
very much.
really represent a lot of the heart of the institution.
Thank you. Thank you. Wow. What do I do with that?
Dr. Romano.
So we're back at the summary of the medical staff. On the first page, you'll see the applications in process. There are 7 pre-apps representing a variety of specialties, and 8 applications in process, 2 of whom are general dentists, and 2 of whom represent cardiothoracic surgery from the East Bay Cardiovascular and Thoracic Associates. There are 2 of many who are looking to join us in the courtesy staff, and 6 of applications have been withdrawn. On the next page, I'll show you a summary of the current members. We have 544 total, including all categories of medical staff and the allied health professionals. That filters down to 403 active and provisional active members. Medicine remains the largest department with 210 members, surgery following that, in second place with 123. And on the third page, you'll see the 2 applicants that you acted on this evening. And that's my report.
Great, thank you very much, Dr. Romano. Nancy, we have the calendar.
Go ahead, Joe.
Past health promotions and outreach events. On January 8th, 10th, and 11th, Nancy Farber, Chief Executive Officer for Washington Hospital Healthcare System, conducted 3 CEO brown bag informational sessions for staff. She provided information on hospital census, staffing, financial results, Measure Z and the limitations on its use, and the Affordable Care Act, and construction. Approximately 350 people attended. On January 16th, as part of the Washington Women's Center Lunch and Learn program, Anna Mazet, registered dietitian, presented Healing Soup. Whether comforting a cold, nurturing a friend, or enjoying with your family, soups can be healing. 3 different soups were prepared during this live cooking demonstration. 35 people attended. On January 17th, Christy Caracappa, Health Insurance Information Service Coordinator, presented to the Dawn Breakers Lions Club on health insurance, what you need to know. 22 people attended. Washington Urgent Care and Washington on Wheels Mobile Health Clinic have been offering flu vaccinations to the community since September. However, in response to one of the worst flu seasons in recent years, Washington Hospital held additional flu vaccination clinics on January 17th, 18th, and 24th. These clinics were open to community members ages 3 and up. 316 people were vaccinated. On January 23rd, Washington Hospital hosted Brownie Troop 31355 for a tour of the simulation lab to learn how clinical staff are trained to provide quality, safe patient care. In addition, students participated in a hand hygiene presentation held in the Community Health Resource Library. 19 second grade students and parents attended. On January 26th, Washington Township Medical Foundation provided a sports physical clinic for high school student athletes. Students from American, Irvington, Washington, and Mission San Jose High Schools in Fremont and Logan High School in Union City participated. Each student received an assessment and physical to ensure they are healthy enough to play sports. Dr. Russell Nord, Orthopedics, provided the examinations. 44 students received sports physicals. On January 26th, Washington Hospital hosted the annual abdominal aortic aneurysm screening. Aneurysms develop over time and may have no symptoms, but if one bursts, it can cause immediate and life-threatening symptoms. Dr. Ash Jane, cardiologist, Dr. John Thomas Mahegan, vascular surgeon, and Dr. Gabriel Herskew, vascular surgeon, were on hand to interpret results from this Doppler screening. This event was sponsored by Fremont Bank. 108 people were screened. Of those, 4 were identified with dilation of the aorta, and 4 abdominal aortic aneurysms were detected. On January 29th, Dr. Gabriel Herskew, vascular surgeon, presented treatment options for varicose veins and chronic venous disease. This event was co-sponsored by Washington Township Medical Foundation. 30 people attended. On January 30th, Kimberly Alvari, registered dietitian, presented on gluten sensitivity to employees of Boehringer Ingelheim. Boehringer Ingelheim is a worldwide pharmaceutical company with a facility located in Fremont. 20 people attended. On February 5th, Patricia Danielson, Washington Township Healthcare District Board member, and Ruth Traylor, Director of Community Outreach, presented on Careers in Healthcare at Newark Memorial High School's annual career fair. 53 students attended. On February 7th, as part of the Diabetes Matters education series, Dr. Ash Jane, cardiologist, presented Protecting Your Heart. 25 people attended. Upcoming health promotions and community outreach events. On February 13th, from 7:45 a.m. to 8:30 a.m., Christy Caracappa, Health Insurance Information Service Coordinator, will present on California's Health Insurance Exchange to the Optimist Club of Newark. On February 19th, from 1 p.m. to 2:30 p.m., Dr. Sanjay Bindra, cardiologist, will present Keeping Your Heart on the Right Beat, Atrial Fibrillation. On February 23rd, from 10 a.m. to 12 noon, the Washington Center for Wound Healing and Hyperbaric Medicine will hold a free foot screening. If you have diabetes, poor circulation in your legs, or neuropathy, you need to take extra care of your feet. The clinical team from the Center for Wound Healing and Hyperbaric Medicine will take a look at your feet and give you private, personalized lessons on how to care for your feet. On February 26th, from 1 p.m. to 3 p.m., Dr. Lucia Jumena, nephrologist, will present World Kidney Day, Acute Kidney Injury. On March 5th, from 12 noon to 1 p.m., as part of the Washington Women's Center Lunch and Learn program, Dr. Arun Srivatsa, gastroenterologist, will present on colon cancer. On March 6th, from 6:30 p.m. to 8:30 p.m., Christy Caracappa, Health Insurance Information Service Coordinator, will present Medicare, Are You Turning 65? On March 7th, as part of the Diabetes Matters education program, Dr. Achana Bindra, endocrinologist, will present Diabetes Update 2013, What's New? The Washington Hospital Healthcare Foundation report. On January 28th, the Foundation held its annual meeting for trustees and members. At the meeting, trustees elected the following individuals for new trustees: John J. Dutra, Mayor Bill Harrison, Lamar Hinton, and Dr. John Romano. Also elected as members were Sandra DeBar, Mary Jane Hodges, Risha Killaru, Suzanne McEwen, and Laura Stewart. The meeting was the last one that Demetrius Schaefer, Fire Chief of Alameda County, chaired as president of the foundation. During Chief Schaefer's 2 terms as president, the foundation contributed over $5.4 million to Washington Hospital. Nancy Farber, executive vice president of the foundation, presented Demetrius with a commemorative crystal eagle to thank him for his 4 years of leadership. The incoming president of the foundation is Carol Dutra Vernacci, Mayor of Union City. Trustees also seated Rodney Silvera as vice president, Craig Silcox as treasurer, and Helen Kennedy as secretary. At the annual meeting, trustees approved the disbursement of $526,000 to support a wide variety of clinical services at Washington Hospital, including breast brachytherapy, Washington on Wheels Mobile Health Clinic, the Community Mammography Program, and the Cancer Genetic Screening Program. The Washington Township Healthcare District Board of Directors report. On January 30th, Washington Township Healthcare District Board members Patricia Danielson and Dr. Bernard Stewart attended the annual State of the State luncheon hosted by the Tri-Cities Chambers of Commerce. On February 8th, board members Patricia Danielson and Dr. Bernard Stewart attended the Elegant Affair hosted by the League of Volunteers. Washington Hospital Employee Association, WIA. Each year, the Washington Hospital Employees Association, WIA, designates a specific amount of money raised during the year to fund donations to hospital departments. The WIA wish list is a way of saying thank you for supporting WIA during the year. This year, 20 departments submitted requests, totaling $21,000. WIA was able to honor 14 of those requests for a total of $7,500. Washington on Wheels, WOW, Mobile Health Clinic. During the month of January, Washington on Wheels Mobile Health Clinic, also known as WOW, provided healthcare services at the Fremont Senior Center. In addition, WOW provided flu vaccinations to community members during 4 flu shot clinics held during the month. 316 flu shots were administered. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was January's most viewed web page with 16,365 views. Other active sections include InHealth, Channel 78. Washington Hospital's cable channel 78, InHealth, aired new programming during the month of January, including a health and wellness seminar on Alzheimer's disease and the January Board of Directors meeting. Several public service announcements from the Center for Disease Control focused on the flu also aired in January. Other updates. Our community, like much of the country, is experiencing an increase in flu-related illnesses this season. We encourage people to get vaccinated. Vaccination is the first and most important step in protecting against flu viruses. People 6 months of age and older should get the flu vaccine. In addition to getting vaccinated, everyone can help prevent the spread of the flu and other viruses by washing their hands often and thoroughly using soap and warm water. When hand washing is not an option, alcohol-based hand sanitizer is a good alternative. The flu vaccine continues to be available throughout the remainder of the flu season while supplies last from 8 a.m. to 8 p.m. 7 days a week at Washington Urgent Care. Appointments are not necessary. Washington Urgent Care accepts most insurance plans or will administer the vaccine for $10 for those who want to pay cash. Washington Urgent Care is located at 2500 Maury Avenue, Washington West Building, 2nd floor. For more information, call 510-791-CARE or visit whhs.com/urgentcare. The Washington Township Medical Foundation clinics throughout the Tri-City area are also offering the flu vaccine for $10 while supplies last. For locations, hours, or more information, call 866-710-9864 or visit mywtmf.com. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070.
Right. I'd like to supplement that report with the announcement of our Employee of the Month. True Nguyen joined the pharmacy department in August of 2005. He is known to be a highly dedicated and resourceful pharmacy technician. He's self-directed and works well with a minimum of supervision. Accuracy and quality are his first priorities, which is very important. His main task is to ensure that the best sterile techniques are used on all of the IVs that he makes. He's well-liked, he has a calm demeanor, and an ability to focus that's earned him the respect of his peers. He continues to seek and accept responsibilities and new challenges. In addition, he's a team player and always goes above and beyond to help other technicians finish the work that's before them. With the recent high census, he's been excellent in assisting the pharmacists and fellow technicians to run a smooth and efficient pharmacy with this increased workload. He can work fast, but his accuracy still remains high, and accuracy is perhaps the single most important factor here. He's a valuable asset to the pharmacy and to Washington Hospital, and this is why his supervisor, Mintu Denon, recommended him, along with his coworkers, to be our Employee of the Month.
We'll now move on to our quality report. Stephanie Williams is going to talk about infection prevention update.
Thank you, Dr. Nicholson. Tonight I'm going to give you an update in terms of what's going on with our infection control prevention program here at Washington Hospital. One of the goals of our infection prevention program is to provide surveillance, prevention, and control activities to support the overall hospital mission. Infection control is mandated. It's mandated by CMS, it's mandated by Joint Commission, it's mandated by the state. So it's what we do in the hospital to protect the patients. Our goal is to identify risk of infections and opportunity for infection prevention measures to prevent and reduce the risk of disease transmission. One of the purposes of infection prevention is also to improve patient safety by decreasing the incidence of hospital-acquired infections. When you talk about infection prevention, you hear a lot about it in the news today. A lot of it is data reporting. We do have internal and external transparencies in terms of where that data goes. We report data to the CDC. They have their own national database, and it's an annual voluntary internet-based surveillance system integrating patient and personal safety surveillance. They have over 3,000 facilities in that database. We also submit data to the Center of Medicare and Medicaid, known as CMS. And this too is mandated in terms of every agency asks for different information, so it's not one information that's necessarily going to all areas. The California Department of Public Health often state mandated data when we submit our data for the state through the CDC. And then you have the Alameda County Public Health Department, where we have ongoing reporting of communicable disease reporting. Let's talk a little bit about the infection prevention structure here at Washington Hospital. We do have an infection prevention consultant. She's our liaison, Dr. Diane Martin. And for the board, you saw that little heart. I love washing my hand. That was her idea, and she did the work herself, and that was asked to be given to you guys tonight. We have an infection prevention program coordinator that has oversight for the infection control program, as well as the infection control preventionist. In the old days, they used to be called infection control. Now it's infection control preventionist. So I think they're making in progress. We have a committee, a medical staff committee that has oversight for all the infection control activities. And this is a multidisciplinary committee that has physicians from different disciplines, and the function as that control agency, because this too is also mandated as part of the Joint Commission. We also have a multidisciplinary infection prevention committee, and that is an internal committee that is multidisciplinary. We have every discipline in the hospital participating within that committee. You have dietary, you have environmental services, you have pharmacy, lab, the OR, central processing, facilities, construction, quality, and these are just a few of the departments that do participate on a monthly basis in those meetings. Talk a little bit about prevention surveillance, infection prevention surveillance. This is not all that we do, so this is just a snapshot of some of the things that we do. Hand hygiene is very important for us, and this is February is Heart Month. It's also when we have a hand hygiene blitz. Protect your loved one, protect yourself. So we are really focused on hand hygiene because that's one of the single most deterrent in terms of preventing infections in hospital. We have employee health, where we have certain metrics that we have to monitor and report. We have isolation compliance. Every patient that goes in an isolation room has to adhere, and the staff have to adhere to strict isolation practices. And then we also have surveillance that are mandated in terms of what we surveillance. We talk a little bit, and you hear every so often about the surgical site infections, and it includes your hips, your hysterectomy, your spinal infusion, just to name a few. And then we have brought the hospital-acquired infections here that are being monitored and being reported, such as your central line infection, your Foley catheter infection, your C. difficile, and your MRSA. Construction is a big deal in terms of infection prevention. So they're very much involved in protecting the staff, also protecting the patient. So as much construction as we have going on right now, there's always a risk assessment that's done before every construction, and that too is signed off by both the contractors and our staff. Sterilization includes making sure that the equipment that we use are the cleanest as possible without any bacteria. So there are standards that must be met for those as well. Environmental cleaning in collaboration with environmental services. An example is for the EVS department, for isolation rooms, they have a two-pronged cleaning. They clean first with an approved disinfectant, and then they go back and they clean what's called the high-touch area. And most of you cannot see this, but you will see all the red sign. They go back with bleach wipe, and they clean the headboard, the core lights, the phone, all the areas that the light switch, all the areas in the room. And that's the second phase of the cleaning. And that's done with Clorox so that it can clean anything that's left behind, including C. difficile, any of those bacteria can be eradicated. And then we have the Multidisciplinary Antimicrobial Stewardship Committee. And you have heard Dr. Martin present here before. And that is looking at antibiotic usage and duration of antibiotics. Let's talk a little bit about some of the mandated reporting that we do. The state mandated per Senate Bill 1058, and it's been in law since 2006, and it mandates that we screen the following population for MRSA. We have to screen all patients that go in and into critical care. Inpatient dialysis, if they come in, they had dialysis, they were screened on admission. If they were negative on admission, they have to be screened again on discharge, and that has to be done within 24 hours of discharge. Any patient that come to us from a nursing home, any patient that's been in another institution within 30 days. So if the patient has been in another hospital, they come to our emergency room or they come for surgery, those patients need to be rescreened again. And patients undergoing the following surgical procedures, any kind of cardiac surgical procedures and laminotomies or laminectomy as in with the spine surgeries. Let me give you a little bit of data as it relates in terms of what our data looks like. And this is with the surveillance at Washington Hospital in terms of the critical care. The goal is 100%, and as you see, we have not met that goal. It doesn't mean that it wasn't done, but it has to be done within 48 hours. It's not 48 hours and 2 hours. It's not 50 hours. It's not 60 hours. So the screenings are being done, but it has to be done. It doesn't matter what's going on with the patient at that point in time. It has to be screened to be counted and to be compliant. And again, we have worked with the staff and we have come up with ways in terms of where we can increase that compliance. The other metric we look at is the MRSA blood infections. And for the last 3 quarters, we have had no bloodstream infections. Look.
I heard that correctly.
Pardon me?
That last statement you made.
For the last 3 quarters, for the MRSA bloodstream infections, we have had none.
0.
0.
Good, good. What we're doing is effective.
You heard a little bit with the community report about influenza season, and that too is now being mandated in terms of the reporting. Alameda County, as of November 1st, required that all employees that come in contact with a patient be vaccinated. So you may be in the hospital at times and you may see the staff wearing a mask, and that's because they may have had some allergy to the vaccine and they're unable to do that. But because they haven't been vaccinated, they have to wear a mask at all times. CMS has also implemented a new core measure looking at immunization, not just for influenza, but also for the pneumonia as well. And they have targeted all patients greater than 5 years of age with a length of stay of less than 120 days. And we have started collecting that information. Thank you. Here are some of the results of our influenza. In 2011, 80% of our staff were vaccinated. For 2012, over 90% of our staff have been vaccinated, 91.4%, and that's the staff. The physicians are close compliance as well. They have been doing a good job in terms of the vaccination. When you look at the patients, for March of 2012, 85.9% of our patients receive vaccination. And again, there could be reasons why they haven't received it, or sometimes they opt to take it on the outside with their primary doc. But it's offered to every patient that comes in the hospital that meets the certain criteria to be vaccinated. Let's talk a little bit about surgical site infections. And these are the certain surgical procedures that are mandated that they be followed. The first one we're going to look at here is colectomy. and we had 77 procedures done in fiscal year 2012. And we had 2 infections. And remember, at this point in time, the surgical site infections have to be followed for a year. So it doesn't matter whether they came in, they went home, they were fine, they ended up someplace else. But if there is anything related to that procedure, then that's considered an infection. So the duration of the time in terms of when we can compile that data is within 1 year. But again, our rate is a lot lower than the national rate. And this comes from the CDC, where they have over 3,000 hospitals participating. And
Stephanie, our rate looks to be about half the national incidence.
correct.
The question I have for you, and you may or may not be able to answer this, do you know if we can demonstrate, based upon our number of cases, whether that is statistically significant? I don't know if your biostatistician has addressed that or could address that.
I think right now with the CDC, that's what they're trying to do as well, because right now they just give us the raw numbers and
Right.
tell us where we stand. But that's the next step. So in maybe another 3 to 4 months, we should get a report back from the CDC telling us whether or not we're above the statistical, if there's any significance to it.
Right, good.
But this is how every hospital right now looks at the data based on the information that's given to them. Looking at total hip replacement. Again, we had 1 case of infection in over 488 procedures. And again, this is following the patient for a year. So it doesn't necessarily mean it was acquired in the hospital, but the fact that that patient had a infection within that year, it gets counted. And again, ours is 0.2, but look at the national rate, it's 1.3. For abdominal hysterectomy, we had no infections, whereas the national rate is a 1.6. Let's talk about some of the things that we have done and we continue to do in order to get the numbers that we're looking at, in order to promote patient safety and to decrease the risk to the patient of hospital-acquired conditions. We have ongoing surveillance and monitoring of infections. We do a lot of education both to the community and staff employees, including physicians. We have a comprehensive multidisciplinary infection prevention rounds. We engage the nurses to play a more active role in the critical patient care management. They are the ones at the bedside. We get them engaged, we get them involved, because they are the one that can change your practice at the bedside. Increase the number of respiratory etiquette stations. Well, what are those? When you go into the hospital, you see those stations out there. They're throughout the hospital. They have a box of gloves, they have masks, and they have the alcohol hand sanitizer. And it's well used, because we can tell you, and often in the day, how often those are changed. We offered flu vaccination free to the employees and physicians. And we take the data. We get that data on a monthly basis. And that data goes to all the committees that it needs to go to. And we look at our data and say, how are we doing? What can we have done differently? And this is where our infection control consultant comes in. She looks at all this data in conjunction with the medical staff, in conjunction with the infection control liaison committee, and say, okay, what can we do differently? So that's an ongoing process that we have in place. Some of the changes that are coming for 2013, they want more stringent additional requirement as it relates to MRSA. They want to know now not just that the blood bacteria infection, but they want to know if there's any kind of sepsis associated with it, and if there's any resistance, what kind of resistance is there. They're doing the same for C. difficile. They want to know exactly if it's related. They want an ID event. They want to know if it's related to cleaning, whether it's related to antibiotic usage. They're getting down to the granular level in terms of requesting information. The vaccination rate for all employees who have worked at least 30 days need to be reported as well. For the surgical site infection surveillance monitoring, they have made some changes. They're no longer following implants procedure for 1 year. Now they're going to do that for three months, 90 days. And they have gone from the 1 year to the 90 days monitoring for the spinal infusion, cardiac surgery, heart transplant, just to name a few. And that's fairly new. We do all of our reporting through the CDC NHSN database, and they too have become more user-friendly. They're being a lot of requests are coming to them in terms of asking for the data to break the data down to the granular level. So that is something that we should be seeing in the next few months as well. So it's an ongoing, evolving process. Even for them, this is fairly new. Okay, we used to report a ventilator-associated pneumonia. And, we have gone over 3 years without having a ventilator-associated pneumonia. Well, they have changed the criteria for that. So they have gone from ventilator-associated pneumonia, known as VAP, to ventilator-associated events. And the events is more inclusive in terms of they're asking for more information. Before it was pneumonia, now is anything that relates to the respiratory status. It could be pulmonary embolism, it could be edema, it could be sepsis. Any of those can fall into that category. Now it's lab tests, signs and symptoms. It's a lot more objective than it had been previously. So we have begun to collect that data, so you should be hearing and seeing more about this data in the months to come. And as February is hot month, it's also Valentine's month, so protect yourself and protect your loved ones. Thank you.
Thank you, Stephanie. Outstanding results there with real import to the community. Any questions or comments to Stephanie from the other board members? Great, thank you very much, Stephanie. Let's move on to our finance report. Chris Henry. How's your arm doing, Chris?
Oh, it's coming along. I should get out of this torture device sometime next week.
Okay, good.
Thank you for asking.
Sure, you're looking more mobile lately.
Okay, so tonight we will be looking at the operational and financial results for Washington Hospital for the month of December. We'll move right into our acute inpatient statistics. Average daily census for the month came in 28.6 lower than we expected in the budget at 165.9. We had 1,003 admissions. We'd expected 110 in the budget. And our patient days came in about 885 below the budget at 5,143. So our admissions were down about 9%. Our census numbers down about 14%. So that what falls out of that is we saw an average length of stay that was less than what we'd expected at 4.75. We'd expected an average length of stay for December of 5.43. Something I do want to mention, though, before I move on from these statistics, is those patient day numbers don't include observation. We haven't talked about observation days for quite some time. And just to remind everybody, there are a group of patients that present here at the hospital with certain diagnoses, such as chest pain, syncope, TIA, that for various reasons are judged to need to be watched for 24 hours or more in some cases. Some of these patients are admitted and some of them go home in 23 hours and in certain cases 48. Those patients that go home by government standards are considered outpatient. However, while they're here, they are in an inpatient bed consuming the same nursing resources and other resources as many inpatients do, yet they're not reflected in these numbers, and observation is becoming more of a factor. So as we move through the next period of time, we're going to be focusing a little bit more on observation. I did want to note that for December, we had 279 outpatient observation days. So we had 279 days where one of these patients was in an inpatient bed but considered outpatient. And for the year to date, we've had about 1,704. That's 195 days more than we expected in the budget. And when you look at the rates against our inpatient days, that's about another 5%, both on an outpatient base or on a year-to-date basis and for the month. So we're going to be reporting observation days more because they are growing and becoming more of a factor. Looking at utilization, case mix index for the month came in at 1.569. Again, less of the medical patients in the house. We saw the low census numbers driving up that case mix index. We had 160 deliveries in December against a budget of 151. Our surgical cases were 8 above the budget at 348. That included joint replacement cases that were 17 above budget at 102. Our neurosurgical cases came in right on budget at 16, and our cardiac surgical cases came in at 19, 11 above the budget of 8. General surgery was 20 below, so driving that total variance at 8 cases. PTCA procedures for the month came in 8 below budget at 148. However, our total cath lab procedures for the month were 40 above budget at 398. So while we weren't doing the PTCA business, the cath lab was busy. Outpatient visits for the month came in 644 below budget at 7,829. However, the emergency room was extremely busy, 4,512 visits against a budget of 4,300. So the emergency room continues to operate at a frenetic pace. Looking at our productivity very quickly, December saw a total of 1,293.6 productive FTEs and 140.7 non-productive FTEs, giving us total FTEs for the month of 50 that were 50.2 below the budget at 1,434.3. Our FTEs per adjusted occupied bed, which is our productivity measure, came in above budget at 6.69. We expected 5.99, although as you'll see in a while, those numbers came into line in January. So, moving into the financials, total patient revenue for the month came in almost $5.3 million below the budget at $174,905,000. Our contractual write-offs for the month landed at pretty close to budget at 75.96%, giving us net operating revenue that landed $1,473,000 below the budget at $42,334,000. Operating expenses for the month came in little more than $2.1 million below budget at $41,121,000. We saw the variances in salaries and benefits with our lower FTEs. Purchase services were below budget, and our reserve for charity and bad debt came in a little bit lower than budget in the month. So we ended December with an operating bottom line of $1,213,000, about $665,000 above the budget. Non-operating income for the month came in $682,000 below the budget at $445,000. That includes an unrealized loss in our investments of $1 million. And I also always like to remind folks that it is by definition unrealized. That number represents the change in the market value of our investment portfolio in the month. And essentially, if we sold our entire portfolio on the last day of the month, that would have been our loss. So we end the month with a total bottom line really close to budget in December at $1,658,000. And that's our Governmental Accounting Standards Board presentation. Very quickly, we'll look at our Financial Accounting Standards Board presentation. This is the way the financial markets tend to look at us. Operating bottom line doesn't change at $1,213,000. We pull out our property tax revenue, which is used to service our general obligation bonds, and that unrealized loss on our investments to come up with non-operating income from a FASB perspective of $747,000 and a total bottom line of $1,960,000. So are there any questions on December's results?
No, very good, Chris. Thank you very much.
Sure.
Let's go on to operations.
January?
Yes, please.
Okay, remind everybody, these are preliminary figures for the month of January. We saw 1,078 patient admissions that resulted in 5,964 days of care. The average daily census in January was 192. This was higher as compared to December's, which was 166. The high and low ranged from 199 down to 154. The January observation patients accounted for 338 days with 270 discharges. The budget had called for 280, so we're seeing significantly more in the way of observation than we had initially planned. The budget for January anticipated 1,176 admissions and 6,378 days of care and an average daily census of 206. So we're going to come in approximately 414 patient days of care below the budget for this month. The average length of stay for adults and children in January was lower than budget. It came in at 5.13. We had anticipated in the budget that it would be 5.42. In terms of patient mix, our preliminary information indicates that inpatient revenue for the month of January amounted to approximately $145,687,000, compared to the budget estimate of $152,341,000. Of this amount, 55% was Medicare, and just 6.7% was Medi-Cal, which is still reflective of very slow processing of Medi-Cal applicants for eligibility, which is of significant concern, knowing that our state is going into the exchange as one of the first states to do so, with the plan to bring significant numbers of people into the Medicaid program. And so I'm not quite sure what's going to happen over the course of the next few months that's going to change the processing. It's of concern. Let's see, we'll go to births. We saw 164 deliveries in January compared to a budget of 173. We had 356 baby days of care. Newborns totaled 167, so we had some twins in there. By comparison, a year ago in 2012, we had 152 deliveries. Surgery was, again, very busy. There were 391 surgical cases at the hospital. Our budget had called for 364. This includes cardiac surgical cases that came in one below the budget at 8 in number. The inpatient surgical activity was above budget by 31 cases, and the outpatient surgeries came in below budget by 4. 544 cases were seen at the outpatient surgery center versus a budget of 560. For the month of January, there were 443 cases seen in the cath lab, including 44 PTCAs. Total cath lab cases were higher than budget by 106, a 31.5% positive variance. And PTCAs were also higher than budget by 10, or a 29.4% positive variance. Inpatient cath lab procedures were 52 more than anticipated in the budget, while outpatient procedures were 54 higher than expected. The cath lab has been the focal point of a great deal of activity. In terms of outpatient visits for the month of January, we had 10,422. They were 11.9% higher than the budget, a variance of 1,106 more visits, and they were higher than the January visits a year ago. The emergency room recorded a total of 4,949 patients, a daily average of 160. That is absolutely huge, and a lot going on in a very small space. 533 visits above the budget. Washington, Warm Springs, Newark, Nakamura, Ohlone, and Walmart clinics saw approximately 4,406 patients during January, 249 less than in the budget. Our total system emergency room and clinic visits for January were 9,355, compared to a budget of 9,071. In terms of personnel, full-time equivalents for the month of January totaled 446.6, including 8.6 agency personnel. This was 72.4 lower than the budget. But FTEs per adjusted occupied bed came in at 5.8, which was at budget. Let's see. We'll go to the summary. January had 8.3% fewer admissions, 6.5% fewer patient days than anticipated in the budget. Surgical cases were above budget by 7.4%. Cath lab procedures were above budget by 31.5%. Outpatient visits were 11.9% above budget, while ER visits were 12.1% higher than anticipated. Clinic visits came in about 249 visits less than we had anticipated, or a 5.3% negative variance. Total paid FTEs are below budget by 4.8% for the month and below the last 12 months average by 31.8 FTEs. Inpatient charges for the month were lower than budget by approximately 4.4%, or $6,654,000. Outpatient charges were higher than the budget by approximately 4.7%, by $1,941,000. Total hospital charges for January were below budget by approximately 2.4%. On January 31st, there were 161 days cash on hand. Total days revenue in accounts receivable at January 31st was 61.6. The days revenue in accounts receivable excluding Medi-Cal was 56.3. During the month of January, $2,779,403 of charges were approved for pending or charity assistance. I think that's the biggest number yet. Beginning to push up against $3 million a month.
Right. Very large number and consistent.
Yeah.
Thank you very much, Nancy. At this point, we're going to move on to our action items, and Mr. Wallisher, the motion maker for item A.
Mr. President, I move for the reappointment of Russ Flowers, Ben Saw, MD, Shirley Buskey, James Stone, and Miro Garcia to the Washington Township Hospital Development Corporation Board of Directors for 2013.
Thank you. Do we have a second?
Second.
Second from Dr. Stewart. You'll get the next one.
Okay.
All in favor?
Aye.
Aye.
I think we just need to thank these folks. These are wonderful, wonderful things they do.
Indeed, and hard work.
Yeah,
Very hard work.
and they're willing to do it again.
Yes, they're very generous.
Yep.
Item B.
Mr. President, I move for the reappointment of John Lowe, Garrett Yee, Jack W. Balch, Al Wazo, and Kevin Hom to the Citizens Bond Oversight Committee for 2013.
Do we have a second?
Second.
Okay, second from Director Danielson. All in favor?
Aye.
Aye. Motion passes. And we again thank the Citizens Bond Oversight Committee for their excellent work. At this point in the meeting, we're going to move on to consideration of at-risk compensation for the Chief Executive Officer. I will conduct this as follows. I will make a brief statement, and then I will provide opportunity for the public to speak regarding this specific agenda item. Following that, I will ask input and give opportunity for the board members to present an action item, and starting with Mr. Wallace. So it's important for us to focus on what we're discussing here tonight. We are not discussing a salary increase for our CEO. As noted in our December meeting, our CEO made herself part of the management salary freeze and elected to forego any consideration this year of an increase in her base salary. This was despite information that the national average increase in healthcare executives was approximately 3% for 2012. At that December meeting, we indicated that a portion of the CEO's compensation is at risk.
Tonight, we will be discussing whether or not to award an at-risk amount, and if so, how much. It should be noted, according to the CEO's employment contract, any incentive pay is to be awarded before the end of the year. Unfortunately, the Board of Directors did not address Ms. Farber's incentive compensation before the year ended, and thus we are doing so tonight. By way of background, it is very important to review the methodology we use in setting the CEO's compensation, since the at-risk award is part of that methodology. Annually, we review the CEO's performance as required in the employment agreement. The district has a long-standing philosophy of wage parity for all employees, including the CEO. Wage parity means the CEO is not paid at the top of the scale, nor is she compensated towards the bottom. The district's compensation philosophy of marketplace parity establishes a base salary for the CEO at around the 65th percentile of her peer group, and a total potential cash compensation for the CEO in the range of the 75th percentile of her peer group, with a maximum possible at-risk award of 40% of the base salary. The peer group, which is used, comprises hospitals and hospital systems of similar size, scope, and business model. In the past, we have engaged an independent executive healthcare compensation consultant to provide the board with a report which shows the board how our CEO's cash compensation compares to the cash compensation paid by her peers. As we mentioned in our December meeting, we did not do that this year, as the CEO decided not to be considered for a base salary increase. However, we will utilize that comparison information from last year's report for the at-risk portion of her compensation. This should be conservative, reasonable, and appropriate because, as mentioned, the national salary increase for healthcare executives was around 3% in 2012. From that report, for our discussion, the 75th percentile from last year's report was $946,000. Our CEO's current base salary is $651,133. If the board awarded a full 40% at-risk incentive compensation, that would bring the compensation well within that figure provided by the executive compensation report of last year. Now let's talk more specifically about the item under consideration this evening, which is the award of at-risk performance compensation. First, I believe that the board's compensation philosophy is appropriate for a CEO with Ms. Farber's level of experience, outstanding track record, and longevity with the district. I sense that our other board members would concur. Over the years, consistent with the standard practice in the industry, the board has granted an award of up to 40% of base salary to reward the CEO for her performance. In my opinion, the CEO's performance this past year does justify an award. We are all strongly aware of the recent financial challenges the district has faced. This is characteristic of what is happening throughout the whole healthcare industry and is not just occurring at Washington. Decreases in reimbursement rates from the state and federal governments, as well as from private insurers, as well as increasing costs, including labor costs. These have all had significant impact on the bottom line. Given the economic conditions, and declining volume, the difficult decision to reduce the workforce was made after much consideration and only after first reducing costs in other areas. Many hospitals in the Bay Area and across California and the rest of the United States have also had to take this difficult step. Making the decision to downsize, or rather right-size, when necessary, is as much a part of being a responsible administrator as is building, growing, and improving the healthcare system. This demonstrates our CEO's strong leadership. Additionally, we are investing in our future through the funding of an electronic health record system, as well as our medical foundation. These are important strategic initiatives that are designed to assist Washington Hospital in remaining competitive in the marketplace and in meeting the requirements of the Affordable Care Act. These two initiatives are moving forward successfully under the direction of Ms. Farber and are important to the ability of the district to continue to provide high-quality care and to meet the health care needs of our residents now and into the future. The following are additional accomplishments that we should take into account in our decision-making. Measure Z, our bond measure, passed by over 73%, an even higher margin than its predecessor, Measure FF. This is, in essence, a clear referendum on our healthcare district. If the CEO and staff didn't have the support of the community, this bond measure would not have passed. Yet it passed with over 73%. Our CEO is overseeing the massively complex and expensive process of transitioning to the Epic electronic health record system. This past year, the Epic infrastructure was completed, and the practice management portion of Epic went live on schedule in our clinics on November 1st. In terms of construction, and you all know we've had an active construction program, our power plant was, as you heard tonight, completed on time and on budget, actually under budget. And all the cutovers to the new power plant went live without any interruption to our facilities. The Center for Joint Replacement building was also finished on time and on budget. Washington has received several awards and recognitions demonstrating outstanding patient care and our commitment to quality. In May of 2012, Washington received the Partner for Change Award from Practice Green Health in recognition of its achievements around waste management. In June of 2012, Washington Hospital received an A grade in hospital safety from the Leapfrog Group, which conducts a nationwide survey of medical centers. The score is based upon an assessment of patient outcome data in 26 different categories, including patient injuries, infection, and medication safety. In July of 2012, the American College of Radiology designated Washington a breast imaging center of excellence. In August, as many have heard, U.S. News & World Report ranked Washington Hospital as the 4th best hospital in the Bay Area. Washington Hospital was recognized for its high performance in 9 specialties. Washington Hospital also scored high in patient safety, demonstrating our commitment to reducing accidents and medical mistakes. In October of 2012, Washington's cancer program received a 3-year accreditation award with commendation from the American College of Surgeons Commission on Cancer. Washington's breast program also received a 3-year accreditation. In October of 2012, Washington Hospital was recognized by the Beta Healthcare Group for its Quest for Zero initiative, a quality program focusing on improving patient safety in the emergency department. Again, in October of 2012, Washington received the U.S. Department of Health and Human Services Bronze Medal of Honor for its work to reduce the number of people waiting for an organ or tissue transplant. Lastly, Washington received numerous awards from Healthgrades this past year, including ranking among the top 10 in California and the top 5% in the nation for joint replacement, along with receiving a 5-star rating in neurosciences and ranking in the top 5% in the nation for treatment of stroke, and receiving the Stroke Care Excellence Award. In summary, the performance of the CEO has many facets. We are all aware that this year, compared to previous years, we have faced financial challenges, a difficult economic climate, decreasing reimbursement from the state and federal levels, and great uncertainty surrounding the future of the nation's healthcare system. I believe the year ahead will be just as challenging. However, members of our community who have come to Washington have always received and will continue to receive the very highest quality of care. That is the fundamental and continuing goal of the board and the CEO. Under Ms. Farber's strong leadership and vision, the healthcare system has achieved many objectives and has been recognized by numerous outside organizations for the quality of care provided. I believe that the leadership strength and the experience of our CEO will successfully lead us through the challenges that lie ahead. Thus, I feel an award at some level is appropriate in recognition of the past year and its accomplishments. At this point, I would invite members of the public to address the board on this matter. There being none, I will open this up to other board members and invite our immediate past president, Mr. Wallace.
Okay, thank you, Mr. President. I want to, first of all, want to apologize if I am somewhat redundant, but I do want to, in some respects, repeat some of the things that you have mentioned because of what I believe to be the significance, and I know you've mentioned many accomplishments, and there were some that came to my mind that were very significant, and I just felt the obligation to say a little bit more about them. The district has always had as its principal mission and goal the provision of quality health care for our residents. In that regard, we have made significant investments this year in the infrastructure of our healthcare system that will benefit current and future residents of the district. Being in business as I have for nearly 40 years, I appreciate the difference between maximizing short-term returns and sacrificing long-term stability. I think that the investments that we have made to our campus and enhancing our campus, for the additional equipment that we continue to make, in some respects may have, as you have mentioned, impacted our short-term performance, but have certainly added to the prospects of our continued survival and relevancy in our community. I also want to mention, as you did, the establishment of the EPIC electronic health record system, which will allow us to have one patient record that captures the clinical information from wherever the patient visits in the healthcare system. This will help us to provide the most timely and appropriate care to our patients. It's valuable information for patients that have a number of doctors that are treating them. And it's also, at a point in time, will be extremely valuable to the patient themselves to be able to access their records from their home or from a medical facility somewhere else in the country. And this is a type of electronic healthcare system that is, in many respects, being forced upon the world by the government, and as we all know, but it's a good force, I think, and it's something that is we are all going to benefit from, but it's very expensive. It's expensive to purchase, it's expensive to install, it's expensive to train people to use it because it's got very little value. If you build it and assume people are going to use it, they have to be trained, and that training is expensive. There's been a significant investment in establishing our medical foundation and attracting world-renowned physicians who are using cutting-edge technology in their practices, and that technology that Ms. Farber and the management team has brought into our district. The Institute for Joint Restoration and Research attracts patients from all over the world as one of the top programs in the United States. This is important because it brings cutting edge, maybe cutting edge is not the appropriate term to use, but it brings very modern techniques for joint replacement and restoration, and it also brings revenues from outside of the district into the district to help with programs that are not compensated at all in the emergency room, or for patients who have no funds at all, in which we have to provide charity care. That money for those programs has to come from someplace, and it just doesn't pop from the sky, and it has to be earned. And the Center for Joint Replacement is one of those places in our campus where that additional revenue is earned. I'm talking about a building in the central utility plant, which is a major accomplishment, and it was the first step in the rebuild of our campus, which was required by the seismic retrofit upgrades that were mandated by the state, and incidentally not funded at all, not one penny by the state. But in the end, we will have a new campus here. The next stage will be the building of our ICU, CCU, new emergency room, and cardiac facility adjacent to the hospital. These investments, coupled with additional pressures of healthcare reform, have affected our bottom line, and there's no doubt about that. However, as long as I'm a board member, I'll continue to support investments in improving the quality of health care for district residents. In my view, it's our duty to do so. Now, our CEO, Nancy Farber, has done an admirable job in very difficult conditions, including incredible financial pressures. Making investments in the future is the wise thing to do, but clearly on a short-term basis can have a negative impact on the district's finances, as I have stated. She has made tough and unpopular choices. The easy thing would have been to kick the can down the road, which is what we see happening all the time in Washington, but she didn't do that. We talk about experience. I think the value of experience is often ignored or undervalued. She is worth more to us because of her institutional knowledge than someone that is going to be new to our institution. And one day that will occur, and we will lose that institutional knowledge. In many respects, it's unfair to compare her compensation to the average compensation or certain levels of compensation out there for others. Because that, in my view, that premium for experience is often ignored. But given her level of experience and given what the district has accomplished this year, I do think an award is appropriate, and I agree with you. I would not be in favor of the maximum award, but I believe we have, in my mind, two options. An option, option one, which I'll call an award in the mid-range, is appropriate, but I would favor an amount that is slightly higher than the mid-range. Or we can settle on option two, in my view, which is an award in the mid-range. In order to facilitate a more focused discussion, I'm prepared to make a motion. And so at this time, based on the performance of Mrs. Farber, including but not limited to the accomplishments mentioned here tonight, that the CEO be granted an at-risk award of 25% of the base salary. And I want to say why I believe in this upper end of the range that I have stated. Under normal historic circumstances, and let's call that pre-healthcare reform, standalone hospitals, and our hospital is a standalone hospital, have faced challenging times. That's before healthcare reform. Many have been under the threat of closure or merger with monolithic systems, and the result of this is less local care for patients. Big does not mean better quality or more responsive health care. My belief is that hospital consolidation and its negative effects are not what the residents of our district want when they elected us to this board. Now more than ever, it is critical that we hold in place quite possibly the best management team assembled in our state. This team is not a new, unproven team. It is a team that has delivered high-quality service over a long period of time, through good times and bad. The results of what they have produced under Nancy Farber's leadership didn't just happen, and they're not a product of luck. It takes smarts, skill, teamwork, and great leadership. These characteristics are not cheap anywhere, particularly in the healthcare marketplace, and certainly not in our new uncertain reality. The results of this team's work are among the reasons why our medical staff has grown and continues to grow and is mentioned tonight to 544 total physicians. These physicians know the importance of doing their life's work in a place with great staff, great state-of-the-art equipment, and focus on care of the highest quality. We have what physicians seek because of our leadership. I don't want these talented professionals stolen from us by those hospital systems who cannot bring the same attributes to bear for their patient bases because of their inability to assemble the talent that we have here. And I don't want our leadership and management team wooed away by those monolithic systems willing to pay market compensation, which is a risk if we are not willing to do so. That ends my comments.
Thank you, Mr. Wallace. I appreciate your comments. My personal opinion is I agree with your motion. I think that is where I was thinking as well. We have a motion. Do we have a second?
Second.
Thank you, Dr. Stewart. Would you like to comment?
I think I would. In situations like this, I like to step back a little bit and see myself as a citizen of the district, which I am. I've lived here for longer than I care to say. Actually, I've lived here for 50 years. And I feel a very, very strong affinity to the hospital and to this community. When I first started working on the hospital board 10, 12 years ago, I was impressed with the goodness of this organization and the quality of people that are here. Good, honest people with tremendous integrity. I can't say enough about the staff, the administration, and my fellow board members. Good people. There's no doubt about the fact that we're presented at the moment with unprecedented challenges. Challenges that, to be quite honest, are scary in some respects, based on our history, but based on the challenges that are ahead of us, it really is a very, very scary situation ahead of us. I'm afraid we as the public don't totally understand the difficulties facing our healthcare system. It's interesting to me to know that the baby boomers are coming of age. Did you know that there are 10,000 per day joining the Medicare system? 10,000 per day new Medicare recipients. The Affordable Care Act will funnel more people into the Medicare and Medicaid systems, overloading those systems that are already unable to pay the going rate for healthcare services. It is a tremendous challenge for this organization to meet that, along with all of the other unfunded mandates. Mr. Wallace has spoken about the electronic medical record. Tremendously valuable system, but expensive, to say the very least, both in time and money. I had the opportunity today to see one of my physicians and was introduced to the new electronic medical record. It took my physician and a nurse about 20 minutes with the system to get me registered and get me up to date and get me all into the system. Now, all of that time, my physician could have been seeing someone else. And those are lost minutes, lost productivity. And our hospital is facing that challenge, both with the medical practices in the community and with our very practices here in the hospital. We absolutely need, as Mr. Wallace has said, the very best brains and management skills available to us. Our medical system is facing unprecedented challenges. In today's environment, the pay for a successful, experienced CEO is what it is. Market conditions indicate that we are absolutely considering what needs to be considered to maintain a management team and CEO in this hospital. It's a temptation for all of us to compare the CEO's salary with other elected officials or other public officials. But I can't stress in the strongest means possible, that is an absolute error. That is an absolute problem that will lead to only other discussions that are not productive. I am absolutely certain that the salary numbers we are considering here tonight are appropriate because they meet the standards of the healthcare around us. We in this hospital are a public hospital. We are a public elected board, but we are engaged in an incredibly competitive and difficult business. And we are different from any other public organization in that regard. I believe we are extremely fortunate to have the talented CEO that we have, that has a she has a past history of success. She's made difficult decisions at difficult times. She has maintained this hospital and this management group in a way that, as I said before, is incredibly impressive to me. I am very much in favor of the proposal made by Mr. Wallace. I believe that the at-risk incentive compensation should be awarded in that 25% of base salary range. I believe that's absolutely appropriate. I believe it's absolutely fair. I believe it's something this board really needs to do.
Thank you, Dr. Stewart. Dr. Eapen.
I pretty much concur with everything that has been said, and I don't want to be very repetitive, but I think the key thing that I would like to bring this onto the table is that, we as a board, and the numbers, we didn't just pull it off the air. These numbers came from a very reputable healthcare compensation consultant group that's called Integrated Healthcare Strategies. And they have one of the largest data bank for the executive salaries, about 17,000 in the country, about 1,000 hospitals in this country. So this 65%, or the 58, 65, 75 we are talking about is a parity that has come from across the country. And with all the accomplishments that the CEO and the hospital team has done for the hospital, Nancy Faber has been the CEO for the last 19 years in this hospital, and as it was mentioned, the U.S. News and World Report ranked Washington Hospital as the 4th best hospital in the Bay Area. Health Grades ranked Washington Hospital in the first 10 in the state. I think these are all accomplishments that didn't come easy. I mean, it takes a lot of courage, a lot of teamwork, a lot of decision making, especially in this time of uncertainty with a new healthcare reform coming, with a real bad financial climate, low reimbursements from the state and the feds. I think it's not easy at all to make and get all these accomplishments. So I have no hesitancy to support the proposal made by Mr. Wallace today to have at-risk compensation of 25% of the base salary.
Thank you, Dr. Eapen. Director Danielson.
Thank you. I suppose it's my job now to wind it up. The board is responsible, and I don't want to be redundant either, and I do concur with everything that my fellow board members have said. But I also have a few things that I would like to point out that seem to be very unique from my perspective. The board has the responsibility to hire one employee. Not all of the staff in the whole healthcare system here, but just one employee, and we need to keep that in mind. We also need to keep in mind that this is a very complex healthcare system in multiple communities, and each one of these communities are different. Just like sisters and brothers that are united because they're part of that one family, they're the same, but they're each one different. And there's a uniqueness there that has to be dealt with each one of them. We've also had some very trying financial times in the past, and I believe we're going to have some extremely financial challenging times in the future. I can't believe all the changes that have happened. Back in the 80s, I was somewhat discouraged, was looking for a new career. I couldn't find anything that appealed to me more than what I was doing, so I stayed in healthcare. And the reason I was looking for something different was because nothing was happening. It was kind of stable at that time. And so I blame myself for what happens because it has been nothing but constant changes ever since then. Now, tying this all together, we have that one single employee that we have hired or was hired for this hospital. Over and over again, she has demonstrated her creativity with all of these different challenges. And many of those have been said tonight, and I don't want to repeat all of those. In these very trying financial times, look at the accomplishments that have been made. You listed probably several pages worth of accomplishments. And I am very proud of the staff, but I am more proud of the individual who is the team leader. So there's several words that came to mind when I was listening to my fellow board members, and one was to describe Nancy Farber. Dedicated, intensely dedicated. She's a team leader. If you look at any industry, nothing happens without a good team leader. They're the ones who set the tone for everything else that follows. So to remember all of the accomplishments that we've had this past year, and prior to that, it's because we've got a good team leader. The staff are following her lead. We've got excellent staff, but she's the one that pulls them together into a tight team and keeps it all moving forward. She's also a very caring individual, not just for the staff, but for the residents in the community. And we are in a caregiving industry. So showing care is a part of the whole package deal. And I'm very, very pleased with the accomplishments that she's had. So I do agree with my fellow board members that 25% of the base salary is very appropriate, very deserved, and I'm very proud of this healthcare system. I'm very proud of each one of the staff members who work here. Each one of them, I don't want to say they're always surprising me, but their dedication. And remember I said dedication is one of the words that I wanted to use to describe Nancy. It's shown every single day, day after day, event after event, the dedication that everyone has toward providing the best quality care that the system can ever give. And I concur with everyone else.
Thank you, Pat. So the motion before us from Director Wallace was that an at-risk incentive compensation award of 25% of the base pay be awarded Ms. Farber. The motion was seconded by Director Stewart. Catherine, if we could have a roll call on this?
Yes. Director Nicholson?
Aye?
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eapen?
Aye.
Thank you. Motion passes. Thank you very much, Nancy, for your hard work and dedication to this great institution.
I'd like to thank the board.
We look forward to continuing to work with you. Thank you. All right, we'll move on to item D.
Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to purchase the TEG 5000 hemostasis blood analyzer for a total amount not to exceed $59,405. This purchase was included in the fiscal year 2012-2013 fixed asset budget.
Great, thank you. Do we have a second?
Second.
Do we have a second? Nancy, can you give us some background on this? Yeah.
Give you a little explanation of what this is. During cardiac surgery, a hemostasis blood analyzer system facilitates the physician's understanding of hemorrhaging or forming a blood clot. It also maximizes the platelet function while revealing the strength and stability of clotting agents. Without the information provided by the analyzer, the patient would likely receive more blood products during and after the surgery due to an incomplete understanding of the patient's hemostasis. Anesthesiologists also utilize this information from the blood analyzer to predict probability of a post-op surgical bleed with a 95% accuracy level. This is truly impressive. And this leads to appropriate decision-making around the question of re-exploration surgery and appropriate blood component therapy. And it was something that we budgeted for and something very much needed for our heart program.
Yeah, it's clearly quite useful, provides real-time information to the cardiac surgeons on their clotting status of their patients, minimizing blood products and maximizing safety. Any other discussion? All in favor?
Aye.
Aye. Motion passes. Item E.
Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to purchase the software and hardware to replace the switching matrix in the Security Command Center for a total amount not to exceed $90,700. This software and hardware upgrade is an emergency replacement project and was not included in the fiscal year 2012-2013 fixed asset capital budget. However, the Service League has funded a portion of this purchase through a donation of $55,000.
We have a motion. Do we have a second?
Second.
Second from Director Danielson. Thank you, Sharon.
Yes.
You guys do great work. Nancy, would you like to comment about this?
I'd like to say thank you to the Service League as well. I know that security is everybody's concern, and that we have people coming and going from this building on all 3 shifts, 24 hours a day, 7 days a week. And to have a good security system is very important to the well-being of our volunteers, our employees, our physicians, our visitors, our patients. And approximately 17 years ago, a computer system was installed in the security department. So 17 years should give you an idea of how out of date the system is. Okay? And we've had a catastrophic failure. I think that's probably at least
Must have been Windows
7 or 8
95.
times the cycle that you normally see with computer equipment. So I'd say the security staff have gotten maximal use from it. The surveillance cameras are displayed, the images are displayed on a computer monitor, and individual cameras can be brought up on demand to follow security events around the campus. And it has proved to be critical in providing a safe environment for all of the people I just mentioned. The software and hardware have collapsed. And it has exceeded its normal lifespan by a significant margin. The replacement software and hardware for this system will better coordinate digital images that are being fed to the base station from upgraded cameras. Sometimes the images are so indistinct that it's hard to understand what you're looking at. We will have 11 pan-tilt zoom cameras that will be digital and will allow the base station to control the movement of the cameras with improved zoom-in capabilities. The purchase of this equipment will return to total functionality of the base station and allow a minimal number of personnel to monitor the entire campus. The security officers will be enabled to be more efficient in focusing on unusual or suspicious activity and respond immediately as events unfold around the hospital campus. And I might remind the board how critical the security function was during our construction period. On multiple occasions, combination of the security camera system, the guards, and the dogs stopped our construction sites from being pilfered for copper and wire. And as we're heading into a second phase of construction, having a good security system protects the materials that are brought on site, and something that I think is essential. It's not just our safety and security, it's also protecting the assets that are lying on the ground awaiting installation in a building.
It'll pay for itself many times over. Any other discussion? All in favor?
Aye.
Motion passes. Item F.
Mr. President, in accordance with district law policies and procedures, I move the Chief Executive Officer be authorized to purchase 2 Stryker Neptune Ultra systems and a docking station for a total amount not to exceed $49,000. This purchase was included in the fiscal year 2013 fixed asset capital budget.
Thank you. Do we have a second?
Second.
Second from Director Danielson. Nancy, if you could tell us about this.
We have 7 Stryker Neptune Ultra systems for the operating rooms, and we're requesting 2 additional units and a docking station to make sure that each operating room and the operating rooms in the perinatal department are equipped with the same equipment. There's a tremendous amount of safety and improved functionality with that. What these pieces of equipment do is collect smoke, evacuate smoke from a surgical field, and they're a fluid waste collection system as well. These trap and remove the smoke that's caused by cauterization from the surgical field, and it carries a vacuum system that removes liquid waste from the surgical field. And this particular system is very finely tuned and controllable at the bedside. It's better than ordinary suction machines. The disposal system stocked with a waste removal system in the OR, which allows biohazardous waste to be disposed of with little or no exposure to the staff in the surgery. So it also has this element of improved safety for our employees and our physicians.
Great. Thank you very much, Nancy. Any other discussion? If not, all in favor?
Aye.
Aye. Any opposed? Motion passes. This completes our action items for this evening, and at this point, we will now adjourn to closed session. We are going to reconvene to open session and announce that no action was taken in the closed session. And there being no further business, this meeting is adjourned.